Hi, good afternoon or morning or evening, wherever you're tuning in from. Thank you so much for joining us today for our conversation on gender and COVID-19. I'm your host, Francesca Donner, Gender Director at The Times. Research has shown that men and women respond to viruses in different ways. We've seen that with a host of viruses in the past and present, from influenza to HIV to Ebola to SARS, and we're seeing it play out today with COVID-19. We know that around the world, more men are dying from the coronavirus than women, even though infection rates for men and women are more or less the same. Researchers have found sex differences in every tissue and organ system in the human body, including the immune system, writes Caroline Criado Perez, who I am delighted to report is on the call with us now. But what is maddening, my colleague Alisha Haridasani Gupta has written, is that despite the fact that we know being male is a risk factor, we're not really tracking that data in the US. Caroline Criado Perez is the author of the book Invisible Women, a brilliant, if dispiriting read about how the world is very biased towards men. And Alisha Haridasani Gupta is gender reporter at The Times and the writer of the In Her Words newsletter. We're going to kick off this conversation with a few questions from me to Caroline and Alisha, and then we'll move to questions from you, our audience. Please feel free to submit questions at any time during the call using the Q&A feature in Zoom. Also, please note that the call is being recorded. So, Caroline, welcome.
You're dialing in from... very much for having me.
Dialing in from London. Alisha dialing in from New York. It's lovely to have you. I thought we would start a little bit just talking about some of these known differences between male and female immune systems. That seemed quite surprising to me. Caroline, I'm wondering if you can elaborate a little bit on that.
Yeah, so I have to be honest. The truth is we don't actually know that much about the difference between male and female immune systems. And really this pandemic is being a real sharp shock, I think, to a lot of people. About the fact that there really are these significant sex differences that can manifest in terms of responses to diseases. The reason we don't know that much about the sex differences is simply that we know far more about the male immune system than the female immune system, because historically we've preferred to study the male body for pretty much everything. The idea is that the sort of female body is just sort of too complicated to account for in our nice, neat medical research. You know, all those messy hormones, nobody really knows what's going on there. Let's just use the nice, neat, universal male body because that's basically the default template for humanity. So we don't know that much about the female immune system and why it is more active than the male immune system, although we do know that it is more active. The hypothesis is that it's because women are the ones who give birth, and that the female immune system has evolved around that. This can be bad for women in that women make up 80% of those with autoimmune diseases, which obviously can be very severe. Women also tend to have more frequent and more adverse reactions to vaccines as a result of their more active immune system. And actually, you know, several researchers have been calling for male and female versions of the influenza jab as a result of this. But as I said, we don't exactly know why that is. But interestingly, there was one study that I came across in the course of my research that I felt was quite sort of tantalizing in terms of what it potentially revealed, where more than two cells, but anyway, male and female cells were exposed to estrogen and then exposed to a virus. And the female cells were able to use the estrogen to fight off the virus. The male cells were not able to do that. What was really fascinating about that, of course, is that it shows that there is not just a hormone response going on, but also a specific cell response going on. But the issue is that that trial is quite unusual in that it studied both male and female, and even more unusually, sex disaggregated its data. So we're kind of flying blind a little bit here. We know that women are more likely to survive, although as perhaps we'll go into, we don't necessarily know exactly why that is, because we aren't collecting enough systematic sex disaggregated data. But we don't really know why that is.
So, I mean, this was first. Well, forgive me, Alisha. I know you. I know you've covered this in some of your work for the Times as well. So I wanted to give you the opportunity to hop in and really quickly if there was anything that you wanted to add. I mean, the interesting thing to me is that what Caroline has said is that we've really studied male bodies as the norm, and anything that sort of deviates from that is not the norm. And I'm really curious if Alisha or Caroline, if either of you want to speak a little bit to what that means to how we understand women's bodies. I guess the idea would be that you just think, oh, a body is a body is a body. But what we're finding, at least from what Caroline has just explained, is that when you look at the cellular level and the hormonal level, there are all sorts of differences that we haven't really accounted for.
Yeah, and I just want to say, that estrogen study, which Caroline just mentioned in her book, I read that too, and it's just like she said, very tantalizing. It's very interesting, and there is a historical tendency not to study the female body. It was only in, I believe, one second, let me pull this up. Caroline, do you know when in the US? Oh yes, in the 1990. Yeah, exactly. 93, when US lawmakers required the National Institute of Health to include more women and minorities. So you know that they've been excluded, and you needed Congress to step in and say, hey, stop, we need to include women here. But even despite that sort of law being passed, it hasn't really been implemented as quickly or as wide scale as we would have hoped. There was a report from 2015 that more women than men were enrolled in trials from 2005 to 2014, but it's unclear in which areas they were studied. And whether that includes heart disease, whether that includes Alzheimer's, whether that includes cancer, we just don't know. There's no breakdown of where these women outnumbered men. So it doesn't give us a complete picture at all.
I mean, I would, without, seeing those figures, I would suggest we might have an idea, just simply on the basis that there has been some meta-analysis of, for example, and this was more recently than 2015, I can't remember the exact date of these meta-analyses, but they were more recent than 2015, which found that men were still significantly dominating in heart disease trials. Women make around 20 to 30%, depending on the stage of the trial and when and what they're looking at. And it's even worse for something like HIV, even though, of course, women are more likely to be HIV positive. But women made up, for example, only 11.1% of participants in antiretroviral studies. And, with regards to the NIH ruling, while of course that's incredibly welcome and incredibly important, and so is the 2016 ruling that this had to be applied to animal studies, we still haven't got any regulation on cell studies. That only applies to trials that are funded by the NIH. It doesn't apply to privately funded trials, which of course are the majority of trials. And it also doesn't apply to generic drugs, which are in fact the majority of trials overall.
Just to put a figure to that point, in 2015, only 22% of total spending on medical health and research was federally funded. So truly, it's a very small number.
It's really interesting because I feel like sort of efforts were made, but it feels very token. It's almost makes you think that it's sort of a nice to have or a guideline, which isn't necessarily something you have to follow. Do you concur?
Well, it's incredibly frustrating. There are so many really fantastic researchers who are pushing so hard for this, but there is a certain, let's say, fairness, I guess, to it. And, just in the past 24 hours, I've been having people in my Twitter mentions who say that they are involved in medical trials who are defending the exclusion of women. And just to go back to your original question of what does that mean for how we understand women's bodies? Well, it means we understand women's bodies far less. And the result of that is that for all sorts of diseases, we are less good at diagnosing disease in women. So if you look at something like heart disease, women are 50%, this is in the UK, women are 50% more likely to be misdiagnosed than men. One of the major reasons for that is that women don't necessarily present with what are known as the classic, you know, universal heart attack symptoms of pain in the chest and down the left arm. Women can experience those symptoms, but they are more likely to experience what are classically, of course, called atypical symptoms, because the female body, of course, is atypical. And the result of that is that in the US and the UK, women are more likely than men to die following a heart attack. And that has been the case for decades. So it's really frustrating that there are these really serious and fatal consequences, actually, of not studying the female body. And yet you still encounter so much resistance in the research community who will say things like the female body is too complicated, the menstrual cycle will interfere with the results. Well, yeah, it will, but you know, it'll interfere with those results in the real world when the menstrual cycle continues to exist, whether or not you want to account for it. And those interferences, as you might call them, can be very severe. So for example, women are more likely to experience drug-induced heart rhythm abnormalities, and that is most likely to happen in the first half of a woman's menstrual cycle. So, you know, we do need to account for this complicated menstrual cycle, but there is this resistance, and it's incredibly frustrating.
It's quite staggering in a way that the resistance would, it's quite staggering in a way that the resistance would come from scientists who you think would be the most attuned to recognizing the fact that women have hormonal cycles, and actually everyone have hormones, and it's sort of staggering to kind of look at it from that perspective. They should know better. You know, another thing that I've read is that you know, even in medical schools, students aren't really learning about the woman's body. They just learn about the men's body, and then you just kind of extrapolate out from there. Alisha, have you seen or read anything about that too?
Sorry, could you repeat that?
I'm so sorry. I was just talking about how even in medical school, where you think it would be a pretty sort of level training ground for people, you know, medical students are taught predominantly about the male body, and you're just left to extrapolate out from there if you want to know anything about the female body.
Yeah, exactly. And I just want to add to Caroline's point earlier, you know, a lot of, when we published this article on this discrepancy, a lot of people on Twitter said, you know, the reaction is kind of, now is not the time. We're in an emergency, so we really shouldn't be focused on this kind of thing. And but it kind of is counter to what actually should be happening, because we're in an emergency, we should be focusing on this kind of thing. And yeah, it goes back much even before research. It kind of is in textbooks, in school textbooks. And I'm quoting directly from Caroline here in her book. She looked through medical textbooks and in schools and colleges and found obviously that even the diagrams in the books are sort of the male body, you know, muscular, organs, whatever, all of it is all based around the male body. And then it sort of is like, this female body is XYZ compared to the male body. So it goes back to what she said, the default male thinking or mindset.
Right, and I can assure you that I don't think I don't personally have the muscular body that they might be describing in the textbook.
Definitely not now.
I'm really glad, Alisha, that you raised this, the idea of this emergency situation, which clearly the whole world is in. And I think let's start doing a bit of a deeper dive into COVID. So I'm wondering, Alisha, if you can give us a little bit of background on the data, the sex data, and also perhaps what that means for some of our audience, that countries around the world are collecting, and how that compares to the data that the US is collecting.
Yeah. So the US is actually just one of 11 countries in the world that isn't systematically tracking infections and deaths by men and women. And the key word there is systematically. Some states and counties are, and we heard a lot from Twitter followers, you know, that their state is doing it and they're very proud of them for doing it, which is great. But again, it's not really helpful to researchers if it's not consistent and systematic. What can they do with one state's information? And since we published that article last week, the CDC did release another report with updates on infections and deaths that included a race and a sex breakdown. But even this data was a snapshot. It was drawing information from hospital networks in parts of 14 states. So while it is a step in the right direction, and it definitely confirms the trends that we've seen in other countries in that men are dying more than women, it just goes to show how the collection of this data in the US is sort of patchwork. It's not baked into the system or the thinking.
Right. Caroline, do you know if this is the same in the UK?
Yeah, unfortunately, we have a similar issue, and yeah, it's really frustrating. So we have various different types of data sets, some of which are sex disaggregated, but none of which are complete. So for example, we have critical care death rates published by sex, which seems to be coming out weekly, but that doesn't include Scotland. Wales seems to be collecting cases, the sex disaggregated data on cases, but England, Wales and Northern Ireland are not. And we have some ONS data, which is just England and Wales, which is thoroughly out of date by the time it comes out. And again, is only publishing death rates, and that's again only for England and Wales. So, you know, like Alisha was saying, for the US, there's this kind of patchwork that suggests it's not really being taken seriously. And the thing that is really frustrating is that, you know, people will defend it and say, well, it's just too difficult, you know, we've got to focus on other things. Well, then why is Italy, which is absolutely struggling so much with this pandemic right now, you know, they are the epicenter in Europe, why are they managing to do it? Why is Germany managing to do it? There are so many countries that are managing to do this. Well, the reason that they're managing to do it is that they recognize that this is a priority right now. Why is it a priority? Because it could not be clearer that there are sex-specific effects to COVID. Men are more likely to die, but we need to know to what extent and what is causing that. And the way you know that is by collecting sex disaggregated data. So we need to know who is being tested, because that will tell us how much we can trust the case numbers. So different countries may say different things about whether men or women are more likely to get COVID. In Wales, for example, it seems like women are way more likely to catch it, which is a massive outlier. Most countries, it's much more equal than that. But the reason you would need to know that is because you need to know, are men dying in higher numbers because they're more likely to get it? Or are men dying in higher numbers because when they do get it, they have a more adverse reaction to it? And without systematic data, we just can't answer those questions. And in terms of needing the testing, you know, who are we testing? Are we only testing people once they're already critical? Well, that will inevitably skew towards men as well. So yeah, it's just so frustrating watching this play out, you know, because I sort of feel like, you know, having written this book and having been talking about these issues for so long now, and talking about why we need sex disaggregated data, and now here is this pandemic showing that yes, there can be very important sex specific responses that we need to account for, and yet, you know, the country that I live in and the country that you live in are not collecting and publishing this data.
Right. And I mean, I also think that, you know, women are more likely to go seek medical care. Maybe they're the ones who are going to the doctor. Maybe they're the ones who are being tested in the first place long before they get into critical conditions. So, I mean, it is maddening, as you say. But I think let's take it up a notch here. You know, obviously we want
you really took it up a notch, Francesca. You can't keep taking it up a notch. How many notches, just so I know, how many notches are we going to go up?
Let's put everyone on edge here and take it up a notch. And you know, we know that they're not having the data is problematic. We know that it's patchy, but I want to talk about this and the implications that it has as we search for a vaccine, because, you know, earlier in this call you said, you know, that I believe the influenza vaccine might be too quote unquote strong for women or whatever. So I think really sort of let's look at that as we're sort of scrambling to find a vaccine as soon as possible, and also just sort of the irony that we don't have time to collect gender data, and yet we're scrambling to find a vaccine. Therefore, the more data we have, the better it would be, surely. I'm going to put that out to both of you. So I don't know if Caroline, if you want to go first, and then Alisha, or vice versa.
Well,
okay.
You're meant to choose.
Sorry. Caroline.
We're very obedient, well-behaved women, you know, we don't go first without being told what to do. Yeah, so I mean, it's frustrating. Again, sorry, I know I keep repeating myself, but you know, Alisha wrote about this very well a couple of newsletters ago, about how, again, it's patchy. You know, some trials are testing on women as well as men, and understand the importance of that, because, you know, of how we are seeing that there is this difference in male and female immune systems. And, you know, let's not forget, yes, men are more likely to die, but women are dying as well. You know, they also need a vaccine that is going to work for them. So you need a vaccine that's going to work for women as well as men. But some trials are still doing that same old excuse of women are too difficult to recruit, women's bodies are too complicated. And so we're just going to start off in men, you know, the default humans. And then if we find anything interesting, we'll add the complicating female factors at a later date.
Right.
So it seems to be happening all over again. And yeah, I mean, on a slightly different note, you know, one of the people who, the sort of groups of people who are most exposed are those who are frontline workers, so healthcare workers, but also, you know, cleaners and carers. And that is a female dominated workforce. And they are absolutely people who are going to need a vaccine. So we have to be creating a vaccine that is going to work for the people who are going to be saving other people's lives. But so far, the evidence does not look that promising in terms of what is actually being studied.
Yeah, Alisha, can you speak to some of the examples that you wrote about? And you're absolutely right. The social element is really, really serious, especially as women are on the front lines. And I know you've written about that a lot as well, Alisha. So maybe you can tie those two things together.
Yeah, so just for some context, vaccine and drug trials in the US go through 3 phases. Phase 1 is to determine basic facts, like, is this safe? Does it work? Are there any severe side effects? And what is the correct dose? So currently, the National Institute of Allergy and Infectious Disease is already in phase 1 human trials of a potential vaccine. And it's interesting because they say they're doing this trial on 45 healthy adults, I quote. And the key word there obviously is adults, because they're not considering sex at this point. And I reached out to them and I asked them, are you taking men and women equally? Are you disaggregating that data? Are you seeing the influences on men and women separately? And they said that they would need a larger number of participants for that for them to be able to disaggregate data by sex. You know, which is like Caroline said, it's not difficult to enroll more people. It's kind of like they're just not looking. And then I asked again, can you give me a breakdown of the 45 adults that you have enrolled? How many are men? How many are women? And they just said both men and women were enrolled. So they're not giving me a breakdown here. But it's not to say that it's impossible to have disaggregated data right from phase 1, because Johnson & Johnson said that that's what they're going to be doing when they head into human trials in September. They're going to be sex disaggregating data right from phase 1. So it's not impossible. So I hope that answers your vaccine question. The social element, like you said,
sorry, break in for 1 second, because I just want to agree fervently with you, Alisha, and also to say that, you know, even if you don't have enough women in your trial to constitute a big enough sample, you should still sex disaggregate your data, because what can then be done is meta-analysis, you know, when various trials have been done. And this is how we discovered, you know, we've discovered some really important things, like, for example, a type of pacemaker that meta-analysis revealed the threshold was set too high for women, and women were being denied it and therefore dying unnecessarily because it was set at a male threshold. And the only reason we were able to do that meta-analysis is because while the individual trials didn't include enough women to be statistically significant, by combining them together, we were able to come up with something really important. Anyway, sorry, Alisha, carry on.
Yeah. No, that's fine. And I just want to point out, there was a small study in Brazil that was halted early because of safety reasons. They realized they were trying out the drug chloroquine for coronavirus, and they realized that it led to irregular heart rates. And this kind of goes, but they weren't disaggregating by sex. They just say patients in the study. And this goes back to the thing that Caroline mentioned earlier, that about heart disease, women aren't really researched in heart disease. And so, you know, when they say it developed irregular heart rates, I just wonder, Do they mean men and women equally, men or women? Obviously that question is always lingering.
Yeah, and I mean, if you don't have the data, you can't answer it. It's really
exactly.
scary.
Yeah.
I'm going to bring you both back to the question of the social impacts, the social gender impacts, which we sort of touched on with the frontline workers. Because we actually have a question for a reader from a reader, forgive me. So Sarah asks, are there any data efforts looking at the social, as in the non-health gender impacts of COVID-19? I'd like also perhaps, Alisha, just because you've written about it so much, I'm wondering if you can speak a little bit about what that means, and then just speak to any data that you've seen regarding that.
Yeah. So thank you for the question, Sarah. The simple truth is that women around the world are caretakers, both professionally and at home, and so that puts them at greater risk. I mean, even the World Health Organization did a report on this back in the 90s that sort of noted that the roles women play puts them in greater danger. So almost 70% of healthcare workers around the world are female, and they're certainly becoming more visible now. Everyone is seeing how clear and true that is. And most of them are in the lower paying and higher risk roles like nurses. Women also tend to be caring for the sick at home. So there is a study from after Ebola that the transmission of the virus was higher inside households than in hospitals, meaning women were probably contracting it by caring for the sick. In the US, women also make up a majority of the other frontline workers that Caroline mentioned, grocery store clerks, cleaners, all of them. And so they're at greater risk of catching the virus. So that's a way of how social norms and roles put women at risk, at danger.
I think also the other interesting thing that came up with Ebola is that traditionally women's social role in society was to prepare the body for burial.
Exactly.
And you all know, I'm sure, just how dangerous that would be with a virus like Ebola. I mean, it's just, it can't get worse. So I'm curious, Alisha, and I don't know that we have, because we've worked on a lot of stories together, but whether we've seen specific data related to those social issues that we've come across, or we'll keep looking. Is there anything that comes to mind?
Hold on. So, I mean, yes, that like I mentioned, the Ebola, I don't have the number right off the top of my head, but there is, higher transmission in the household. There is one example I have that's kind of not related to health specifically, but it is so interesting. It's so fascinating. The 2004 Indian Ocean tsunami ravaged parts of Indonesia, Sri Lanka, India, Thailand, and what happened is it ended up killing disproportionately more women than men. And you would think something like a tsunami is it doesn't discriminate, it just kills everything in its path. But what happened in the most highly impacted villages was that fishermen, many of them were fishing villages, so the fishermen were already out at sea in the morning, and so when the tsunami came, they sort of were managed to stay safe on the boat. They rode out the big wave, but when the wave hit land, all these women early in the morning were already sort of preparing their kids for school. They were preparing meals, they were looking after the elderly, so they just simply couldn't evacuate. And so that in that sense, a lot of women died. But then the thing is that a lot of these recovery organizations and aid organizations that went in to sort of help them pick up after the tsunami didn't disaggregate that data. And so they didn't realize this discrepancy, that more women had died than men. And in the end, like if you look at the long-term impact of that tsunami, there was an uptick in child marriage, child pregnancies, a decrease in girls attending schools, because an entire community lost their caregivers. And if aid organizations had noticed that ahead of time, they could have found ways to mitigate that. So this is sort of more how social roles can really impact the long-term efficacy of response.
That's so sad.
Various ways that I mean, I'm not sure necessarily how much data is being collected on it. Certainly, I know there is some work being done on it. For example, in the UK, there's a fantastic organisation called the Women's Budget Group that does a lot of really great work on the low paid and you know, the extent, you know, how women are positioned in the economy, essentially.
Mm-hmm.
And of course, women being the majority of those in involuntary part-time employment, 0-hour contracts,
Yeah.
and the majority of the low paid, you know, they are the most economically vulnerable. And then also there are the statistics that are coming out that really should have been no surprise to anyone, that domestic violence is increasing all over the world. It went up by 30% in China. It's gone up by about 30% in most countries that have released data, actually. And the countries I've seen, I think, are Italy, France, China, UK. Alisha, I know you wrote something about it for the US. And essentially this always happens when crisis hits, you know, when a pandemic hits, when war breaks out, domestic violence, we know, goes up. And the thing that's frustrating about that is in terms of the government response. So not doing the lockdown in such a way that accounted for this inevitable consequence of having a lockdown, which is not to say we shouldn't have done a lockdown, but did we do a lockdown in a way that made it very, very clear to women who were going to be at increased risk of abuse from their abusive partners, how they could still escape, you know, when they were going to be forced to be in a house with them for so long. So, you know, I think it's a really important question about the social non-health impacts of COVID-19, because it is something that tends to get forgotten a little bit, you know, when there's a pandemic.
Yeah, I think it gets overlooked, and I think with preparation and thought and sort of forethought, you can plan ahead for these things. So the tsunami is a great example. Domestic violence, which happens every single time there's a crisis like this.
Exactly.
So, you know, if you had thought about it, maybe, you know, shelters could have been prepared, or some other, you know, there are a whole lot of things you can do if you could put a creative mind to it. So,
which is where Alisha's point about how this is exactly the time we need to be thinking about gender really comes to the fore, because the reason we didn't account for these economic impacts, for the domestic violence impact, you know, these things are all entirely predictable because we know all of this, assuming you are someone who knows anything about gender. But because we tend to just go into crisis mode and think gender doesn't matter right now, we can't think about women, you know, men are dying, let's focus on that. There are all these knock-on effects which can be very serious, and, you know, and they can be health effects as well. So, for example, to go back to Ebola, in the Ebola outbreak, almost there were about as many deaths in terms of maternal and stillborn mortality as a result of resources being diverted away from childbirth and neonatal care to help fight the virus. And that is, you know, again, a failure to incorporate gender into your response, a failure to remember, you know, that women are going to carry on giving birth even when there's quote unquote a war on.
I know.
And that is something that is actually happening in the UK. You know, childbirth centres are being closed, midwives are being diverted, and you know, we don't know what, I mean, we can guess what the impact of that is going to be, and I doubt it's going to be very good. But we need to think more about these kinds of things, and we just aren't. We're just sort of thinking gender neutrally about, we've got to fight the disease, and we have to fight the disease, but we have to fight it in a way that doesn't cause, you know, others equally serious problems.
Absolutely. And I think until you have a really diverse pool of people around the table who are discussing these issues, all sorts of issues are going to be overlooked, because it literally doesn't occur to people to put menstrual pads into emergency packets for healthcare workers and things like that. It's literally perhaps the last thing on a man's mind. So I'm going to this is an interesting question from a reader, and I'm going to have to limit your answers, okay? So Alison, because otherwise we could go on all day. Alison asks, if you could request governments publish specific data on women, men, and COVID-related issues to help make better policy decisions, what information would you push for? So I think I know we kind of want everything, but why don't, you know, Caroline, if you want to go first, why don't you mention maybe one or two things that you would most like to have? And then Alisha.
I think, I would leave it to Caroline because she's the expert on this one.
Okay, Caroline, you're up. One or two things.
I obviously want sex-specific data on symptoms, who is getting tested, who is testing positive, and what the deaths are. I want that. That needs to be an absolute default. That has to be happening right now. The other thing that I really want, and that is impossible to get hold of right now, is the extent to which women are failing their fit tests for their masks. Now, this is incredibly important because obviously if you don't have PPE that fits the bodies of the people who are on the front lines.
Sorry, personal protective equipment. So things like masks and gloves and
gowns.
Okay. Yeah.
Now, this is something I've been talking about for a long time because it's something I cover in the book, where the vast majority of women who have to wear personal protective equipment, PPE, for their jobs are wearing PPE that has been designed for men and therefore just doesn't fit them very well. And of course, in order to protect you, the equipment has to fit your body properly. So if you talk about something like stab vests, you know, that isn't accounting for breasts and therefore is rising up too high on an abdomen, leaving it exposed. But when it comes to PPE for healthcare workers, one of the main things that I'm hearing again and again from women around the world is that the masks are not fitting their faces properly, that women are much more likely to fail these fit tests that are taking place. And the reason I mention the fit tests is that I have been informed that every time someone fails a fit test, a form is filled out. So we should be having that data on whether or not women are being more likely to fail these fit tests, because this is PPE that has been designed for our good old friend, reference man, the default male, whatever you want to call him, that I'm sure the listeners are bored of hearing about right now. But that is an issue, and that therefore we absolutely urgently need to get into production enough PPE that has been designed to fit a predominantly female workforce. Now, that's not to say that we don't need male designed PPE. Of course we do. The male doctors need to be protected as well as the female doctors. But if there are people going out there on the front lines, risking their lives, and like, let's be clear, they are risking their lives. One of the things that makes COVID-19 more likely to be a serious case is the viral load to which you're exposed. And if you're going to be in an ICU, an intensive care unit, you're going to be someone who is going to be more likely to be exposed to high viral load. And we have already seen a number of healthcare workers dying. And that is, in my opinion, criminally negligent, particularly if it is a case of the PPE simply not fitting them. And I've seen a lot of media stories about issues in supply chains for PPE, but I've seen basically nothing on this female-specific issue. And given women are the majority of the frontline healthcare workers, something has to be done about this absolutely urgently. And if I could just prioritize one thing from governments, it would be that.
Right. So actually another reader said, how do we increase the accountability at the highest levels and ensure that national and local governments collect and use this data? But maybe it's, I don't know if that's sort of maybe it's a question of getting your government to sort of realize that these are some of the issues, if you don't overlook them, and these are some of the issues that are really, really actually endangering some of our healthcare workers who are critical. Without them, we can't care for anyone.
Well, I think the media plays a really important role here. So I think this is up to you guys. I'm checking out at this point.
Oh, don't you worry, Caroline. I have been researching the PPE fit test, so I'm on it. I'm on it.
If Alisha's on the case, she's quite relentless. So
because
I'm sort of like,
what we need is these questions need to be asked in those briefing calls. You know, so in the UK, we've got them asking, you know, what about the vacuum in power with Boris Johnson being in the hospital, and you know, why are you U-turning on this? And you know, people don't really care about that right now. We want to know how we're going to save lives, and we want to know how we're going to protect our frontline healthcare workers. And I really want the media to be focusing on that. I know you are, Alisha. That wasn't direct.
No. I'm speaking to nurses every single day to talk about fit tests. Don't worry.
Yeah.
Well, is that something that you're coming across then?
Yeah, definitely.
Oh yeah. So we're almost at the end of our time, but we've got an interesting question from Andrea, and I think both of you might have some fairly interesting places to look. She wonders about sources that you would recommend in order to see some of the data we're talking about regarding the impact of COVID on women. I don't know, Alisha, you and I were exchanging some pretty interesting charts earlier today. I don't know if you want to lead off on that. Maybe just one or two so that we don't overwhelm people with our laundry list. But couple of thoughts.
First of all, I would highly recommend Caroline's book. It's like a Bible for this time in this weird era that we're living in. But I think also there's an organization called Global Health 5050, which is, and their website is globalhealth5050.org, and they are tracking sex disaggregated data around the world. And they're also pointing out which countries are not collecting sex disaggregated data, which ones are, and they're breaking it down by infections and death rates, which is very, very, very helpful. Caroline, do you have any others to add?
Yeah, I mean, I absolutely second, obviously, both of those recommendations, particularly the first one. But yeah, if you're looking for the social effects as well, I would really recommend that you check out the Women's Budget group. They are UK focused, but given the way gender works, you know, these are issues that will hold true for many countries. It's just a question of degree, really, the extent to which they do. So just Google them, Women's Budget Group, and they've done a really great report that came out just a few days ago that's very, very thorough, that is looking at all the gendered impacts. And I see that some people have been asking, you know, about ethnicity as well, and that is something that they do look into. So for example, you know, the workforce, the frontline workers are not only female and low paid, they're also disproportionately Black and minority ethnic women. So I do recommend them for a really great resource, and just they've also actually started a COVID-19 newsletter, so I would flag that as something to sign up to, as well as my newsletter, of course, and Alicia's newsletter.
And ours.
All the
Sign up for In Her Words. Just Caroline, for our audience, just mention your newsletter and where people can go to get it.
I'm not good at this, am I? I don't know. Actually, I know where you can go. You go to my website, carolinecriadoperez.com, and there's a sign up on the homepage there somewhere for my newsletter.
Fantastic.
It's delightful because she includes pictures of her dog, so I highly recommend it.
Dogs, we all need more dogs now. And Alisha, and Alicia's newsletter, which is In Her Words, you can get that at nytimes.com/inherwords. And unfortunately, our time is basically up. We got so many fascinating questions. These are brilliant questions, and I'm sorry we didn't get to ask all of them, or even many of them. But Alisha and I are certainly going to be looking at these quite closely for lines of coverage at the Times. These are really important stories that we need to be telling. So I want to thank you, thank everyone, thank our audience for joining us today. Thank you, Caroline and Alisha, for being here. Today's event is part of a series of daily conversations with New York Times journalists that take place at 4 p.m. Eastern Time. Tomorrow, April 15th, also formerly known as Tax Day in the US, our colleague Shira Overday, who is the editor of our new technology newsletter On Tech, will speak with opinions writer at large Charlie Warzel about the coronavirus and big tech. Please tune in for that. And to see our full slate of digital events, please visit timesevents.nytimes.com. And I just want to thank you again. Thank you, our subscribers. You make our work possible. You make calls like this possible. We are delighted to have you. And that's it from me, Francesca, your host. And I'm saying goodbye.
Bye.
Bye.
Bye, everyone. Thank you.